Hello, everyone. Thank you for joining for this meeting. Dr. Sonia Martinez, she's from the southern part of Spain, from Almeria. She has been adopting a Viva system for transvaginal RFA since 2020. So she has done more than hundreds of procedures already based on her previous expertise doing endometrial ablation. Please, Sonia.
Hello. Well, thank you very much to STARmed and 𝘼𝙙𝙬𝙚, the filial in Spain, for contacting me and counting on me for this meeting. And I'm very glad to share my technique of local anesthesia with all of you and ask all your questions. And I hope you like it and you start to practice it soon. So I would like to explain you the basis of this technique, so that you can see how I do it and since where I practice it. I don't know if I can share my desktop.
It's already shared. Everyone can see the PowerPoint.
Okay. Well, as I told you, I work in the Hospital Materno-Infantil Torre Cárdenas in Almeria, Spain. And I'm going to talk to you about the uterine block with local anesthesia for radiofrequency ablation of fibroids. We started with this anesthesia with another technique, the endometrial ablation with radiofrequency, in 2018. We started with very successfully, and it controlled very well the pain produced during the radiofrequency. So this is how we started. Then we applied this anesthesia in other procedures, such as a hysteroscopic correction of uterine malformations. And when the pandemic started, we couldn't do the ablation of fibroids because we didn't have theaters available to do it. So I thought that if we control the pain for the endometrial ablation successfully, we could do it also for the endometrial ablation of fibroids. So I tried, and I saw it worked. And now we have, in total, with local anesthesia in our hospital, more than 2,000 procedures. And with this technique, we have more than 10 procedures. Now we have about 130. The uterine block with local anesthesia requires a double infiltration around the cervix, the pericervical infiltration, and the fundal block. And it's due to the innervation of the uterus. The two lower thirds of the uterus have an innervation that comes from the inferior hypogastric plexus. But the upper part, the upper third, comes from the ovarian plexus and the superior hypogastric plexus. So if we only do the inferior part block, we don't have accessible via of the we won't be able to control the pain of the upper part of the uterus. Now I want to talk to you quickly about the type of anesthetics we use. There are two types of local anesthetics, the ester type and the amide type. We usually employ amide type in our specialty for conizations or in the deliveries and so on. And if we compare those amide types anesthetics, we can see that there are two groups. The lower ones, like lidocaine and mepivacaine, has a short medium life, and they are not very potent. They are not very powerful in their effect. And the other two, bupivacaine and ropivacaine, have a high potency and a long duration of the effect, about 6 to 8 hours. We also have available levobupivacaine, that is the levo form of bupivacaine is less toxic. In an anesthetic, we have the lipophilicity that conditions the potency, and the protein binding that means the duration of the anesthetics. So levobupivacaine and ropivacaine are the less toxic and have the longer medium life. But levobupivacaine compared with bupivacaine and ropivacaine has a lower neurocardiotoxicity and higher potency. So that's the one that we choose for our work. In other hospitals, they don't have levobupivacaine, but have ropivacaine. You can use either any one of them, okay? Very quickly, I want to talk to you about the side effects of local anesthetics, because it's very important that when we work with these products, with its anesthetic, we have to be aware of those side effects and to try to avoid them. So the most frequent complications are local ones, but the most important ones are the central nervous system's complications and cardiovascular complications. The first that we can see are neurological symptoms. They appear earlier. The central nervous system complications are tinnitus, metallic taste, paresthesia, nausea, vomiting, vertigo, and restlessness. And the first the first cardiovascular sign is hypotension. Sorry. Okay. So it's very important to talk with the patient as she's going to be awake, and to ask her for any of these toxicity signs, and always be aware that the first cause of these secondary effects is the intravenous injection. So I always insist on the fact that you have to aspire every time you instill the anesthesia. What do I need to do this uterine block? Well, where? We have to do it in hospital setting. It's very safe, but for it to avoid complications and to be prepared to solve them quickly, we have to be in hospital setting, but we can do it in outpatient clinic, in local operating room, and we need a recovery room for the patients after the procedure. With whom? We just need a nurse and an assistant. And what do I need? A diagnostic hysteroscope to do the fundus block, infiltration material, and basic resuscitation equipment. And we use those two needles, and a spinal needle of 22 gauge, a cystoscopic injection needle of 35 centimeters long, so that it comes along the working channel of the hysteroscope and can reach the fundus of the uterus. There are many protocols about the infiltration of the fundus of the uterus. Some use 4 or 6 points in the fundus, spread along the fundus, and another ones use an infiltration at both sides of the ostia, of the tubal ostia. That's what I do. So I want you to know that if you do the infiltration, you can use any one of these protocols, not only mine. And about the anesthetics that they use, as you can see, are mainly ropivacaine, mepivacaine, or combined, or prilocaine. And now I'm going to talk to you about the technique. First, we have to do the infiltration of the lower part of the uterus, of the lower two-thirds of the uterus. To do that, we do a paracervical infiltration or a pericervical infiltration. This is the whole technique, but you will see that we can use this one or this other one depending on the location of the myomas. Sometimes for myomas located in the fundus of the uterus, we don't have to do such a big infiltration, such as huge infiltration of the two-thirds of the two lower thirds of the uterus, because it's not really necessary. When we started the technique, we did exactly what we do for the endometrial ablation. So it's a very powerful anesthesia, but we have seen later that we don't have to use such an amount of anesthesia for this procedure in certain locations of the myomas. So I will explain you both techniques, because sometimes we will use this one, the paracervical, and other times we will use the pericervical. For the paracervical anesthesia, we use a mix of mepivacaine at 2% concentration and levobupivacaine at 2.5, and we mix it with 10 cubic centimeters of saline solution. So we have two syringes with 20 milliliters on that we will inject on each side, sometimes at 9 or 3 or at 7 and 5, only 2 injections. But when we do the pericervical infiltration, we do more punctures that can be 6 or even 8, and we use in every syringe 5 milliliters of a mix of pure levobupivacaine at each point of injection. Okay? When we do this injection, we use the spinal needle and we cut the cover of the needle, and we leave 5 centimeters out that will penetrate inside the uterus, following the line between the myometrium and the serosa. As it's not rigid, you can flex it a bit. You can follow this line and inject along 5 centimeters. The technique consists on 1 centimeter. We penetrate 1 centimeter and inject 1 centimeter, 1 milliliter, sorry. Then we penetrate another 2 centimeter and inject the 2 milliliter. So we go on up to the 5 centimeters in depth. Always, I insist, aspirate before each instillation, because we have to avoid the intravenous injection that is the source of most of complications. If you do it like that, the technique is very, very safe. After the infiltration of the two-third parts of the lower uterus, we have to do the fundal uterine block. So we use it for many procedures, as I told you, as endometrial ablation, type 2 fibroids in the upper part of the uterus, malformations like septa, D-shaped uterus, and so on, and radiofrequency. To do this block, we use a hysteroscopy, and through the working channel, we introduce a cystoscopic punction needle, and we reach the fundus of the uterus. We put 1 milliliter at both sides of each tubal ostia, 2 milliliters in each corner, of levobupivacaine at 2.5%, total 4 milliliters. So I have made a protocol of the infiltration points according to the fibroid location. If we have a fibroid in the anterior part of the uterus and in the two-third part of the uterus, we can do an infiltration at 9 and 3 or at 7 and 5, and not in the fundus. It's not necessary, as we're going to work here. We're going to do the punctions here. If we have the myomas in the anterior part of the uterus, sorry, this was a posterior, I was wrong. This is the posterior part. If we have the anterior part of the uterus with the myoma, we should instillate the anesthesia also at 11 and 1 o'clock. So we have to do 4 punctions that can be 11-1-7-5 or 11-1-9-3. We usually do here in 7 and 5 because the innervation of the uterus comes over here, and we get a better covering of the pain. And at last, if we have a myoma in the fundus, we have to do the paracervical block and also the fundal block, as I explained you before. So I would like to show you how we do it with this video. As you see, we cut the covering of the needle and we get out 5 centimeters of the needle, and we do the cervical block, introducing the syringe and the needle not in the cervix, but in the place that the mucosa reflects in the, ¿cómo se dice? In the fundus sac at both sides or around the cervix. And this is the fundus block. As you can see, this is the ostium, and we make the puncture at half a centimeter at right and left of the tubal ostia. This technique takes about 12 to 15 minutes in total to be done. As you can see, the needle has ¿cómo se dice? Bigger part here that avoids that you introduce the needle too much inside the myometrium. It stops. You can pass the endometrium because it's very soft, and when you reach the myometrium, it enters just half a centimeter. So these are results about NovaSure, that are our largest experience. We don't have now 52 patients with that. We have more than 100. The pain we measure the pain with a visual analogic visual scale of pain after the procedure, and we ask about the infiltration, the procedure, and the immediate postoperative period, and the scores are 2.86 for the infiltration, 1.76 for the ablation with NovaSure for endometrial ablation, and the pain during immediate postoperative period was a score of 1.202. And our patients didn't need, after the procedure, only one needed intravenous treatment. Almost half of them didn't even need analgesics after the procedure. And about the ablation with radiofrequency, sorry, I didn't translate this. We have more than 10 procedures now, and the median pain during infiltration has a score of 3. The pain during an endometrial ablation of fibroids is about 3.4, maximum 10. And the pain during immediate postoperative period has a score of 0.9. So I think it's very good. So the advantages of this local anesthesia are, first, autonomy. We don't need anesthesiologist or general operating room. Lower risk than general anesthesia, longer duration of the analgesic effect after the procedure, greater patient satisfaction, better and faster recovery, and lower cost, as we can perform it in a local operating room. So this is one of our patients. We performed an endometrial ablation, but they are also the same as her. And this is how she gets up and goes home. She's perfectly. So I wanted you to see it. So thank you very much. And now I'm glad to ask you all your questions. Thank you.
Hello, everyone. Thank you so much, Dr. Morales, to share your experience and insights. Everyone, please feel free to open your camera or the voice. So feel free to ask some questions.
Dr. Sonia Morales, can I start? If you can see me.
Yes, I can hear you.
Hello, thank you so much. Thank you for your presentation. It was fantastic presentation. I really love your animations and the images. They're very clear and concise. Thank you for that. So what is your take-home point now? Do you do this in outpatient, normal procedure now when you do your radiofrequency ablation of all your fibroids? Do you do this for outpatients? Are there any patients you would triage to having a general anesthetic that you feel, well, actually there are more fibroids to be done here, or it's going to take slightly longer time, therefore this patient should be for general anesthetic, however this patient I can do in outpatients?
Well, the reason that we decide general anesthesia is first the decision of the patient. We should take into account the desire of the patient, and we have to explain before the procedure when we indicated that we usually do it under local anesthesia, but sometimes they really don't want. About the size, it's not a reason to change the type of anesthesia, because the local controls perfectly the pain. If we have a patient with a lot of pathologies, maybe we will decide to do it with general anesthesia, because they would be better controlled with anesthetics, but not for the size of the fibroid or for the time we're going to employ, because as I told you, this type of anesthesia has a long duration. So we have a good control of the pain during the procedure, after the immediate recovery period, and even when the patient goes home. If we do it in the morning, she will be covered up to 5 or 6 p.m. maybe.
Okay, so your recovery period, you keep them for how long within your setting? So once you have done your procedure, how long does the patient stay with you?
Not more than 1 hour. The time that I expend to write all the papers and give her the informs. So if the patient is not well, we have a recovery room where she can stay the time that she needs. But usually they don't stay there more than 1 hour.
Okay, thank you so much. Thank you for your talk.
You're welcome. Thank you very much.
I would like to ask you, Sonia, thank you very much for a very interesting presentation.
Thank you.
You already mentioned about the size, but could you please mention about the limitation of maximum size of the fibroid you are doing under local anesthesia?
Well, we are doing, I think the maximum size that we have done this technique is about 7-8 centimeters. It's usually indicated for less than 6, but sometimes you have 7 or 8, and you can do it as well. We administrate corticoids after the procedure, even mainly in big fibroids, and well, they have a good result. They reduce, but when they are very, very big, maybe it's not the indicated technique. And now we have also other treatments, new treatments like antagonists of GnRH that can reduce the size of the myomas, of the fibroids. And we usually employ them before the procedure when we have a big fibroid, because it makes more effective the radiofrequency if you apply it with a small. It's very significant that if you reduce 1 or 2 centimeters a fibroid, the volume of it reduces much more. You have a very important reduction of the volume of the fibroid. So I think it's very important to use all these new treatments before the procedure to apply it with the fibroids as small as possible, because the result will be very satisfactory and effective.
Okay, Sonia, thank you so much for your talk. Nice to meet you. I was wondering, in regards to the NovaSure experience, have you tried it also without the fundal? Did you try to not use the fundal part, which make the procedure a little bit longer in general, or how did you end up by getting the idea to make both for NovaSure?
I learned it like that. I learned it in 1918, and the place where I learned it was Portsmouth in England, with a doctor called Dr. Francis Gardner. He taught me to do it like that, and that's the technique that I practiced from the beginning. I think it's necessary. I've never tried it without the fundal infiltration, because I was afraid that the patient felt pain, So I always do it like that, and sometimes, as I explained, and based of the very different protocols of fundal infiltration, sometimes that endometrium is very thick, and it's difficult to find the tubal ostia. I have done the infiltration in some points in the fundus, not locating the tubal ostia, but it was also effective. But I always put the anesthesia in the fundus, because I think it works very well. So it's nonsense to try without infiltration and to have a pain. I don't have I'm not in an operating room to have an anesthetic by my side that can put anesthesia. So I have to do a procedure that I'm sure that works, and this one works perfectly.
Exactly, because it would be nice to have the approach that we really know where it's useful and not. So I was just interested in if maybe your English colleague had tried to have, because actually I think maybe some procedures we can also limit with a para and pericervical for people who not have hysteroscopy, maybe access, and so it could be nice to, maybe this will be the tomorrow's
fibroids. If you don't go very high, it would work with the pericervical or paracervical anesthesia.
Exactly.
And even if you do the punction inside the fibroid, it doesn't fibroid doesn't have a sensitive termination, so I think it's not painful when you do the ablation inside. It's painful in the surrounding tissue that has
exactly, and that's what maybe we can. That's actually my question. That what is actually generating the pain when we do this procedure with fibroids?
Yes, it's
Is it the
different.
endometrium? Is it the fibroid? Is it the surrounding tissue? So very interesting to. It's very interesting to the topic is very interesting to see what we actually can where we can arrive in reducing and what is actually painful. Is it because I have got the idea that it's also the vaginal when we go into some kind of positions around the cervix, maybe more than in the myometrium and the fundus.
Yes,
So we need to collect maybe data as well. How many have you been doing? You said with this technique, in how many fibroids?
130.
Okay, so that's great.
Thank you.
Thank you for now.
Thank you very much. You're welcome.
Hello, thank you so much for your presentation. It was very, very good. I have some questions because now we start to talk, all of us. And I'd like to know, at the beginning, do you monitorize your patient with the ECG procedure or no during the procedure?
Yes, we do.
Okay,
We do.
because I think it's important.
And then oximeter and the heartbeat, frequency, and so on.
Exactly, I think it's important. And in the sequence of...
we don't have intravenous punction. We do it.
Yes, I understood. I understood that. I understood. You don't have any things doing, just the monitoration. Exactly, was what I thought. In the question, in the sequence of this question, do you think it makes some? I don't know. I'm really asking. Maybe it's a not so smart question, but I'd like to ask because I was thinking while you were talking. Do you think it works to do when you do the fundal puncture to add some adrenaline or no?
Why? Do you mean for the bleeding?
Just because I think just because sometimes because you could use Lido instead of so many, because the Lido with adrenaline gives you a way of not, I know that doesn't keep so longer the anesthesia, but gives you maybe how can I say, more skills to do that quickly because doesn't have any blood. I don't know. I was saying it was a question that I was thinking while you were doing your explanation.
Well, this is the anesthetics that I learned too, and I think it's good because it has a long effect and it's very powerful.
No, it's really because of that, because it has a long effect and is so powerful. In the sequence of even of the previous colleague was talking, because maybe it's not worth so how can I say, for the pain in that moment, maybe we need not to have pain, but then to keep so long, if we give a little bit of adrenaline, I don't know, I'm explaining because...
You mean because lidocaine is faster?
Yes, yes.
You see that the way I work is first I instillate the anesthesia and then I prepare everything, all the material on. So it gives me the time for the anesthesia to start working. I usually do it like that for calculation and so on. So instead of preparing all the material first and then doing the installation of anesthesia, I changed the order. So it's advisable to wait about 10 minutes, 10 or a bit more, 10 to 15 minutes for the anesthesia to have the whole effect. But if you do it like that, then first you put the anesthesia and then you take the ultrasound terminal and put the protections and start the guide. It gives you time. Sufficient time to do like that.
Just one last question, please. How long you think that you should do medical treatment with all the new pharmacs that we have before to start to do ablation?
Well, minimum 3 months.
3 months. Okay.
With maximum doses without add-back, because that's how you get the maximum reduction of the fibroids. I advise to evaluate the patients in 3 months, and in 3 months, if we get because
20%.
Sometimes you're a bit in a hurry because some patients are trying to be pregnant. So we don't want to lose a long time for the age of the patients mainly. So if we have a satisfactory evaluation in 3 months, we can start the procedure. But if we want the maximum reduction, we should wait for 6 months without that back. It's nonsense to continue a long time with
yes, of course,
because we won't get much more reduction of the fibroid. So between 3 and 6 months, I think.
Okay, thank you very much. Thank you.
You're welcome.
Gautier, please.
Hi, thank you very much for your talk. It was very interesting. I have experience with NovaSure and Cavaterm for the thermoablation and the local anesthesia, and I completely agree with you. We need to perform paracervical plus the fundal block. I tried without the fundal block. It was impossible. It was too painful. So for the thermoablation, we need both of them, paracervical and the fundal block. However, I have a question because I have no experience for the radiofrequency myolysis and the local anesthesia. NovaSure, it's only 2 minutes. Cavaterm, it's 10 minutes, so it's a bit long. And my question is about the myolysis and the local anesthesia, because it may be longer. And how many fibroids can you treat during the same procedure? I mean, is it possible to treat 2, 3, or 4 myoma, or it's possible and it is only one?
I think it doesn't depend really on the number of the fibroids, but it depends on the volume of the whole volume of the fibroids. It shouldn't exceed, I think, 150 or 200 milliliters. So if you have very small fibroids, many small fibroids, you could do it perfectly. If you have 3 big fibroids, maybe you should do it in another procedure to avoid that such a big myolysis, as you said.
Thank you.
And I'm very glad that you tried to do the procedure without the fundal block and see that it doesn't work, because with the anatomic basis, it shouldn't be effective if you don't do the fundal block. But well, I'm glad that you have ¿cómo se dice? Bueno, seeing it in your experience.
It was very painful without the fundal block, and now I use a fundal block. It's very easy, as you explained, and only 2 to 3 or 4 minutes to perform the fundal block. Yes, we need the fundal block for the NovaSure or the Cavaterm thermoablation.
That's it. It's very easy to do it. Thank you.
Sonia, thank you so much for the talk. It was really interesting, and I'm particularly interested about bringing in a local anaesthetic into our service. We're currently doing it a similar procedure using a slightly different device in the outpatient setting, and we'd like to continue to do so going forward. I guess my question again is about case selection. I know that everybody else has asked a very similar question, but in the 90 cases that you described, what is the average size of fibroid that you're ablating? I want to make sure that I'm talking equivalence, given the cases that I tend to treat are in quite large fibroids, approaching that 7 centimeter mark. So I just wondered whether that's the kind of size that you're treating, or do they tend to be smaller to achieve the pain scores that you've described today?
Well, I cannot tell you now really exactly the size of the fibroids because I didn't
Gather that data.
gather that, but in cases of big fibroids, we don't have many of very, very big fibroids because, as I said, we try to do it in fibroids smaller, not bigger than 6 or 7 centimeters, but sometimes we have done it in bigger ones, in maybe 8, 9, not more than 10, never more than 10.
Okay.
Because it's nonsense that you cannot ablate the whole fibroid because you produce a very, very big myolysis, and we try not to do it in bigger fibroids. We prefer to operate the patients. I think it's more effective, mainly in patients who are trying to be pregnant, because if you don't have a significant reduction of the fibroid, the problem will continue there. You know, about the bleeding, you can control the bleeding very effectively. But if the patient wants to be pregnant, and you still leave the fibroid and you don't reduce it very much, the patient will have the same difficulties to get pregnant.
And just as a follow-on, have you had any cases where you've had to abandon due to pain using that? And could you talk to those patients, you know, who they were?
Pardon, can you repeat the questions?
Of course. You had cases where you've adopted this local anesthetic regime, but patients haven't been able to tolerate it due to pain and you've had to abandon.
We didn't have any patient that didn't tolerate the procedure. We finished all of them. It was successful in every patient. Yes, sometimes they felt a bit more pain, but they tolerated it. In all the cases, we didn't have to interrupt the procedure in any case.
Thank you so much. Very reassuring.
Thank you.
Sonia, one more question here. Do you have any limitation for BMI?
No, we don't. As we do it transvaginally, we don't have. Sometimes we have some difficulties for big vaginas with adipotic tissue around, but we don't have a limitation for that.
Okay.
I think it's more safe for obese patients, this technique than general anesthesia. So I think it's preferable to do it outpatient and with local, better than with general in inpatient.
In this case, when the patient is obese, do you increase the dosage of the
local anesthesia?
Yeah.
No, not usually, because we're going to infiltrate an organ that is not significantly bigger because the patient is obese. Sometimes it depends more of the size of the uterus, but as you infiltrate instill the anesthetic in the entrance, through the entrance of the innervation of the uterus, I think it won't change a lot if the patient is bigger, obese, or not. Even if the uterus is bigger or not, we usually put the same quantity of anesthesia.
Okay, thank you.
You're welcome.
Is there anyone further to want to throw more questions? I think we can cover off the
last question. Why do you advise to do this technique in the hospital and not in outpatient clinics if it's so easy and so safe?
Yes, because it has also complications. we haven't had a lot of complications, but as I told you, I've been performing this technique since 2019, and in this time, I have had some complications, and some of them have frightened me a bit, a lot, because so that I prefer to have a recovery, ¿cómo se dice? An anesthetics near from me. Sometimes we have to put intravenous intralipid, that is the product that you have to use if you have an intravasation of the anesthetic, and for the safety of the patient, I think it's better to do in hospital setting. If you are in another building far from the hospital and you have a complication, not only for the anesthetic technique but also for the radiofrequency, because you can have a thermic lesion of an organ or so on. It's not frequent, but you can have it. It's better to be in a hospital, I think. And also legally for us, it's better to do it in the hospital, or in not a big hospital, but somewhere where you can go to a safer place quickly.
Do you give them sedation before?
Yes, we give them ibuprofen and diazepam, 10 milligrams of diazepam. It's just the only medication that we give them.
Okay. Thank you.
You're welcome.
Is it possible to have these presentations sent to us?
Yes, of course.
Yeah. Thank you.
Yes,
yeah,
I can.
That would be.
I can send you. I will send it to Mino with. No sé.
Yeah, I will make sure to share the PowerPoint and the recorded meeting with everyone.
Yeah, thank you.
Is there anyone with some last few questions? Okay, I think we can wrap up this meeting. Shane?
Just a question on, you said perfectly well on the fundal block and the cervical block, but when puncturing the vagina, do you give extra local for it or gel or anything while the needle goes for the treatment itself?
Oh, can you repeat the last part of the question? You told me that I do the cervical punction and fundal punction.
No, do you give as well something for the vagina as the needle goes through the upper part of the vagina, or
because when you do the paracervical punction, you also can get an anesthesia of the vagina, of the upper part of the vagina where you do the punctions. So you don't need more anesthesia at that level.
Thank you.
It's enough. You're welcome.
Okay. Thank you, Dr. Morales, and everyone for taking your time to join this meeting. And we hope that everyone can bring more further benefits for women patients. Thanks again a lot, Dr. Morales. Any last words for everyone?
Thank you very much, although I attended a bit late. I'm Natalie Atala from London, but I'm looking forward to hear, of course, the part I missed, which is very useful. And of course, this is getting our position stronger with having it more under local anesthetic. I think that would be great. And I believe, as you said, the high BMI patients are very, very, number one, I think, indication is the high BMI cases, which we can't take to theater.
Yes, that's right.
So thank you again. Lovely to meet you.
Thank you very much. You're welcome.
Okay, everyone. Thank you so much. Have a lovely evening, everyone.
Thank you very much.
Thank you very much. Bye-bye.
Thank you.
Thank you, Gary. Thank you,
Bye-bye.
Gautier.
Bye.
you. Bye.
Thank you.